the Madhyakerala team and the Kerala IAP for inviting me to share this presentation. Friends, I'm sure that I would rate one of the Kerala IAP as one of the best IAPs. Am I audible, sir?
Yes, sir.
Yes, sir.
I would rate Kerala IAP as one of the best IAPs in the entire country because academically they are really strong, and I have got, as he rightly told, I got a great connection with them also. So with that introduction, let me jump into the fact discussion. Okay, friends, today we are going to have evidence-based CME on the current fever scenarios, particularly in relation to flu. So my talk is going to be for half an hour, and whenever you have questions, please put it in the chat box, or you can raise your hand, so that it is going to be a didactic lecture. It's going to be interactive lecture. So it's going to be down to earth basic practical points that we are going to discuss today. So friends, with that introduction, so now we are in a current scenario where after this COVID pandemic, we've got bundle of viruses and bacteria and other organisms sitting inside our country, causing havoc, particularly following this monsoon. We got lots of viruses, particularly influenza virus. We do have RSV virus, human metapneumovirus virus, rhinovirus, and of course, dengue is suddenly started rising once again back into the scene, and we do have viruses like mumps, measles, Nipah, all those things. So it's a mixture cocktail of viruses that is there in our country, particularly down south following the monsoon. Now we have a surge of both influenza and also dengue. So this topic is really a hot topic. So with this introduction, so we do see lots of young children falling very sick even to an ordinary virus like RSV following COVID. That is because of a phenomenon called immune lacunae. Even the influenza, which behaved mildly a couple of years back, now it is virulent because the whole community, including the adults and children, were at home, not exposed to viruses for 2 years. Then suddenly we came out. These viruses which were dormant, which are looking for an opportunity, now after attacking young infants or older children, ordinary bronchiolitis seems to be a little virulent, and then they enter into ICU. All those things we start seeing, particularly post-COVID pandemic. That's because of immune lacunae. Okay, please mute everyone. Yeah. So my CME is going to be an educational objective with a simple practical management strategy in resource poor setting. A doctor who is sitting in Thrissur or in Kollam or in Kozhikode or in Cochin in a 10x10 room with limited resources, just by applying his knowledge how to diagnose a case of flu and how to manage them. And I'll give you clear-cut WHO guidelines: when to treat, when not to treat, when to refer, when not to burn your fingers. All those things. പക്ഷെ വളരെ ഇമ്പോർട്ടൻറ്റ് ആയിട്ടുള്ള സാധനങ്ങളെല്ലാം ഞാൻ പറയും നെക്സ്റ്റ് ഹാഫ് ആൻ അവറിൽ കേട്ടോ. So fever basically is a friend. It's a controlled rise of temperature which is mediated by thermosensitive cells in hypothalamus. So basically most of the time parents എല്ലാം പേടിച്ചിട്ട് വരും ഫീവർ സാറേ ഉടനെ ഏറ്റവും നല്ല മരുന്ന് കൊടുത്തോ പെട്ടെന്ന് ഫീവർ കമ്മിയാണോ എന്ന് ചോദിക്കും. So the message is, whenever you see a child with fever, please make an empirical diagnosis. The empirical diagnosis consists of 4 components. One is the etiological diagnosis, second is the pathological diagnosis, third is anatomical diagnosis, and the last is the functional diagnosis. For example, if you have a child comes to you with diarrhea, most of the time younger child, non-breastfed child, probably it's rotavirus. Etiologically is watery diarrhea, is small gut diarrhea, probably viral, probably rotavirus. The anatomy is the small gut, not if it is in the large gut, it is bloody stools. The pathology is enteritis, gastroenteritis. First you have a vomiting followed by diarrhea. That's gastroenteritis, that's a pathology. And the functional is because of persistent diarrhea or persistent vomiting, they may go in for hypokalemia or they can go in for dehydration. That's a functional diagnosis. Like that, for every fever, you must make a empirical diagnosis, preferably empirical diagnosis, which consists of 4 components. So basically, as a practitioner, we must educate the parents that basically fever is a friend, unless it doesn't harm the child. You need to treat the cause of fever, not the fever. Because the parents go to medical shop, they give paracetamol, if the fever doesn't come down, they give ibuprofen, if it doesn't come down, they give mefenamic acid. By crook or any means, they bring down the fever. So the child comes to you without fever with a big pneumonia, because they keep on pumping antipyretics one after another. So you have to educate them not to give any other pyretic, particularly during a monsoon season like this, wherein you have lots of viral fevers, not to give anything other than paracetamol. So you need to take some time, educate them, tell them about what is the fever. So having given introduction to this, let us go to a situation wherein you have a 7-year-old school-going child who went to school healthy in the morning at around 8 a.m. ராவில 8 மணிக்கு ஸ்கூல் பஸ் வரும்போது அம்மையை நட்டு டாட்டா காமிச்சிட்டு போகிற பிள்ளாரு 11 o'clock டீச்சர் விழிச்சு அம்மையை எடுத்து பாருங்க 102 ஃபீவர் ஹை கிரேட் ஃபீவர் கொஸ்டின் திருச்சி கொண்டு போய் விழிக்கும்போது மதர் டைரக்ட்லி ஃப்ரம் த ஸ்கூல் ஷீ கம்ஸ் யுவர் கிளினிக் சார் பெட்டுன்னு ராவில போகும்போது நன்னாயிட்டு இருந்து விதின் 2 hours ஹை கிரேட் ஃபீவர் 102 எந்த ஒன்றும் அறியிല്ല உடனே டயக்னோஸ் செய்தோம் അങ്ങനെ வரும் നമ്മുടെ അടുത്ത്. So you have a sudden onset of high grade fever with a severe sore throat and a dry hacking cough, all coming within matter of hours, sometimes with tiredness or loss of appetite and severe body pain, rarely with watering eyes and sneezing. So what could be this? So the $1,000,000 question is, you see nearly around hundreds of children with this combination of sudden onset of high grade fever with multi-system involvement day in and day out. The most important question that arises to your mind is whether it is viral or bacterial. Am I going to give antibiotics or not? So please remember, in vast majority of the pediatric sudden onset fever, vast majority of them are viral in nature. So when I started my career around 30 years back, my antibiotic prescription was nearly 91% of the time. Only 9% of the time I would confidently say it is viral and I will not prescribe antibiotics. Otherwise, vast majority of the time I used to prescribe antibiotics. Now, over the years, after attending many conferences, reading, having discussion with many of my learned colleagues, now I could be able to make a simple viral diagnosis within a matter of 3 minutes when I receive the child. Just by taking a proper history, clinical evaluation, and putting my knowledge, I am able to arrive at a diagnosis of viral within 3 minutes. So I'm going to tell you the secret how to make a diagnosis of viral fever within 3 minutes in your busy OP, and how to reduce the antibiotic prescription. I reduced from 91% to 9%. Now my antibiotic prescription, my day-to-day OP is 9%. The same thing you can do. So we need to do audit for our own self. I've been doing this audit for nearly 30 years. Every time I used to check daily antibiotic prescription, monthly antibiotic prescription, and annual antibiotic prescription. Now it has come to 9%, at par with international standards. So I'm going to tell you over the next slide how to make a diagnosis of viral fever. So this is called a simple 5-point rule, which you can apply to every child who comes to you in your OPD. Point number 1 is sudden onset of a high grade fever in a previously healthy child is, until proven otherwise, is viral. You can ask me why not bacterial. Please remember, these viruses have got ultra short incubation period, within hours or within days, whereas bacteria has got long incubation period. For example, last week the grandmother had a typhoid. Now cherry question typhoid வந்துட்டு 7 days ago. Pneumonia 7 days. So bacteria long incubation period, viruses ultra short incubation period. So sudden onset in a previously healthy child is, until proven otherwise, is a viral illness. Second, more than one member in the family is having fever. First question you need to ask is there anyone in the family, நம்மட ஃபேமிலியில வேற யாரும் வலியமைக்கு இல்ல சரிய கொச்சனோ இல்ல அடுத்து உள்ளவனோ அதுவும் ஃபீவர் உண்டோன்னு ചോദിക്കണം. அப்போ invariably they will tell, yes, yesterday சரிய கொச்சனு ஃபீவர் உண்டாയിരുന്നു சார், என்ன வலிய கொச்சனு ஃபீவர் உண்டோ. and more than one member in the family having fever at the same time is probably viral. Whereas, as I told you, bacteria have a long incubation phase. They will tell that 1 week earlier somebody has pneumonia in bacterial. Whereas in viral, they will tell more than yes, ஒரே சமயத்துல நம்ம வீட்டுல 3 ஆள்காருக்கு ஃபீவர் வந்துட்டாரு. So virus has got propensity to disseminate into the family. During the COVID time, we saw more than one member in the family, more than 10 members in the street, more than 100 members in the colony, more than 1,000 members in the city, more than lakhs of members in the state, more than crores of people in the country, millions of people in the world. So viruses have got this propensity to disseminate, to cause epidemic and pandemic, whereas bacteria does not cause epidemic and pandemic. So more than one member, it is virus. Point number 2. Point number 3 is dissemination of signs and symptoms. Suppose you throw a flashlight and see eye is red, throat is congested, nose is watery. Hello? Can I proceed? Can I proceed? Am I audible?
Yes, sir. Audible.
Yes.
No.
Yeah.
Yes.
Yeah. If the multiple sites are involved, for example, eye, throat, nose, everything is involved, probably it is viral. So dissemination is hallmark of virus, whereas localization is hallmark of bacteria. For example, in the neck you have a big swelling, lymphadenitis, probably bacterial lymphadenitis. Bacteria localized to one place. For example, you have a tonsillar follicle, so group A beta hermaphroditic streptococci, localized to one place. Other places will be normal. So bacteria localizes to one place, viruses disseminated to many sites. Multiple system involved. നമുക്ക് ഇപ്പോ മദറിന് അടുത്ത് എന്താ അസുഖം ചോദിച്ചാൽ പെട്ടെന്ന് മദർ പറയും ക്ഷീണമുണ്ട് സാറേ, ചുമയുണ്ട്, നീർവീഴ്ചയുണ്ട്, പനി ഒരുപാട് കൂടുതലായിട്ടുണ്ട്, വയറ്റുവേദനയുണ്ട്, ചില്ല ചൊറിച്ചലുണ്ട്, ജോയിന്റ് പെയിൻ ഉണ്ട്, ചുമച്ചുകൊണ്ടേയിരിക്കുന്നത്, ചുമച്ചിട്ട് ഛർദ്ദിക്കുന്നത്. That's called verbal diarrhea. Multiple systems is involved. You are able to auscultate, find out rods and bronchi in lower bases, and you got watery diarrhea, you got a skin rash, G is involved, RS is involved, skin is involved, probably it is virus. Whereas bacteria localized to only one system, bacterial pneumonia, bacterial dysentery, only large gut. So bacteria localized to only one system. Whereas if you have multiple systems, it swings the pendulum towards virus. And the last is very important. You have to ask the mother, കൊച്ച് 2 ഫീവറിന് ഇടയ്ക്ക് എങ്ങനെ ഉണ്ടായിരുന്നെന്ന് ചോദിക്കണം. മോർണിംഗ് 8 o'clock ഫീവർ ഉണ്ട്, 8:30 പാരസമോൾ കൊടുത്തു, പിന്നെ ഉച്ചയ്ക്ക് 2 o'clock ഫീവർ ഉണ്ട്, ഇടയ്ക്കുള്ള 6 hours കൊച്ചു എങ്ങനെ ഉണ്ടായിരുന്നു? സാറേ, അവൻ വീട്ടിനകത്ത് നിൽക്കില്ല, പുറത്താണ്, എപ്പോഴും കളിയാണ്, എപ്പോഴും ജമ്പിങ് ആൻഡ് പ്ലേയിങ്. That means normalcy during interfebrile period swings the pendulum towards virus. You can ask me why not bacteria? In bacteria, after giving medicine, the fever will come down, but the child will be remaining dull because of tissue hypoxemia. Whereas in enteric fever or a dysentery or pneumonia, child remain dull even the fever is not there. Whereas in viral fever, the moment the fever touches normal, child be up and about jumping and playing. Just by applying this 5-point rule, you can come to a reasonable diagnosis, probably to the tune of around more than 90% specificity and sensitivity. You can make a diagnosis of short pyrexia, nil localizing, probably viral, without danger signs. The most important thing, what you need to do in your prescription is, as I told you already, you must have guts and courage not to prescribe antibiotics. That's number 1. And second thing is, you must educate every patient with a viral fever about danger signs, because many of the illnesses, they develop danger signs after the effervescence of fever, particularly dengue-like viral illness. The fever will disappear, but the child becomes sick. So communicating to the parents, education about the danger signs, very important than your prescription. What they need is knowledge, not your medicine. So you boldly write short pyrexia, a fever less than 7 days, short pyrexia, nil localizing, no localizing signs, probably viral without danger signs, and send them without antibiotics. The most important message is, whenever you write in a black and white, you just also put your signature name, date, time, your register number, that will save you in the court of law. You mentioned that danger sign counseling given. That's very, very important. So now we have made a viral diagnosis, viral fever. So among viral fever, we have plenty of viruses. Let us focus now. We are going to focus on ILI, influenza-like virus. So these viruses have got respiratory tropism. They have tropism to the throat, bronchial lumen, respiratory alveoli. So they are called respiratory tropic virus. Whereas non-respiratory viruses are your dengue. Sometimes even dengue, it can come with cough and cold. So that's an atypical presentation of dengue or an undifferentiated present of dengue. So you have to basically divide the viral illnesses into respiratory and non-respiratory. So children with respiratory, they will fall under a group called ILI. ILI is influenza-like illness. Influenza-like illness is caused by a group of around 9 viruses. For example, influenza, para-influenza, rhinovirus, respiratory syncytial virus, human coronavirus, even your Nipah virus, all those viruses, coronavirus, everything comes to you under ILI. So basically, these viruses causes, as I told you, sudden onset of high-grade pyrexia. Many of the children will tell you excessive tiredness, lethargy, and lack of appetite. And they will have severe sore throat, difficulty to swallow. That's very, very important. So when you have a child with sore throat, severe sore throat, you must apply modified Centaur score. That's the Centaur score is very, very important. You need to apply for every child. So there are around 4 criteria. To apply that, then you can basically tell whether it is bacterial or viral. By applying that 5-point rule also you can make. So Centaur score you have to apply. Most of these children, the fever will last for 2 days. Then following that, cough will come. Cough will last for 2 weeks. In influenza, in ILI, there is a rule called rule of 2. The incubation period is 2 hours to 2 days. Number first 2. The cough, fever will last for 2 days, 24 hours, 48 hours. The cough will disappear at the end of fever. The cough will last for 2 weeks. In severe influenza, category C, the asthenia, body pain, tiredness, malaise will last for 2 months. So that's called rule of 2. And there is a symptom called acute watery diarrhea in some of the children who have influenza. Some of the children do develop nausea and vomiting along with diarrhea. So that's called gastric flu. Gastric flu is mostly caused by an organism called Norwalk agent. It is bigger than a virus, smaller than a bacteria. It's called a gastric flu. Most of the time, they are all symptomatic and settled down. But when you have a clear-cut fever, sore throat, dry acting cough, and a watery diarrhea, probably you're dealing with, even without doing RT-PCR, you can tell it is influenza A. You can tell H1N1. If there is a watery diarrhea, abdominal pain, with a cough, cold, and fever, hello, please do not talk in between. I request everyone to mute yourself. Okay. So if there is a child with a clear-cut influenza-like picture with a watery diarrhea, probably it is influenza A. You can write even without doing RT-PCR. You will be correct more than 90% of the time. Whereas if you have a child with the same respiratory symptoms, high-grade fever, sudden onset, sore throat, dry acting cough, with severe muscle pain, it's probably influenza B. Even without doing an RT-PCR, you can tell it is influenza. You can even tell whether it is A or B. If more than one member is involved, it's probably A. Multiple persons are involved in the same city or district, probably it is A. B usually sporadic, A is epidemic. In Kerala at present, we got influenza A. So, as I told you already, these 6 viruses, along with this, the new viruses like Nipah, human corona, all those things come under influenza-like illnesses. So, if you look at the symptomatology, there is a big difference between the adult and the pediatric influenza. In adults, the symptoms are more of a non-productive, dry, hacking cough, whereas in younger children, the cough is little less. Though the cough will be for a longer duration, the cough will not be that much hacking. the fever is a predominant sign. In young children, sore throat is a predominant sign, and many of them, because of influenza A, they do have abdominal pain, diarrhea with nausea, vomiting. Whereas in elderly, you please remember the symptoms are more of nasal, rhinitis, watery nose in elderly. So if you have a picture of high-grade fever with cough and rhinitis in elderly, you have to be very, very cautious, because elderly come under comorbid conditions. I tell you how to manage them. Elderly, if at all you see adults also, or somebody in your family. So having seen this, as I told you, influenza A basically causes a significant disease. It infects not only humans, it can infect other species also. Whereas B and C are specifically limited to humans and cause only sporadic illness or minor illnesses. Influenza A is the one that causes pandemic and epidemic. So, as per WHO, whenever you make a diagnosis of ILI, you can write short paraxia, nil localizing, probably viral, without danger signs, probably ILI. You can even write probably influenza. You can even write H1N1. So most of the time you will be right. So you have to categorize them under three categories. The main category is vast majority, 91% of the influenza are mild in nature. They are called category A. And around 8% are called moderate in nature. They are called category B. And less than 1% is category C, which is a severe form. So as a practitioner, if you know what is category A, category B, category C, you can make a 100% scientific diagnosis. Your practice will be 100% successful. Over the next few minutes, without doing tests, how to categorize these patients. Very, very simple. So, as I told you, 91% comes under category A. They all have symptoms, but the symptoms are mild. In these cases, you need not do any test. You need not give oseltamivir. Just isolation. If that's a school-going child, please ask the child to be at home for a week, because influenza has got high strike rate. A child who goes and has some bouts of cough in the classroom, all the classmates will have influenza within next 24 hours. So infectivity is very high. So you have to educate the index case to stay at home, and also not to go in contact with elderly people. So the treatment for such a case is mainly paracetamol. If you think it is ILI, give paracetamol 15 milligram per kg per dose, not to exceed 80 milligram per kg per day. If you think it is DLI, if there is a tender hepatomegaly with respiratory symptoms, tender hepatomegaly or a reduced urination, you need to give paracetamol at a lower dose, 10 milligram per kg per dose, because most of the viruses that mimic flu is another virus, is dengue. In dengue, it's a hepatotropic virus. Your paracetamol dose should be little low. So always you have a co-prescription. Whenever you have a viral fever, give oral, because many of the viruses have got biphasic pattern. Fever will be there. There will be absence of fever for 1 or 2 days. Then they will have immunological fever. That's aviremic fever, afebrile fever. That's because of the immunological. That's because of vasculitis. There will be leak. So you have to give oral. The dose of oral for young children is 50 ml per hour. Dose of oral for older children is 100 ml per hour. Very simple. Please make a point that never yield to patient pressure. Do not give aspirin. Do not give NSAIDs if you think it is viral fever, because you will land up in Ray's syndrome. Sometimes some of the parents will ask you about, shall I give mefenamic acid if it is more than 1 or 2? Never give mefenamic acid, particularly even in children who have febrile seizures, because by itself mefenamic acid is seizurogenic drug. So never prescribe any other antibiotic other than paracetamol. And mild, 91% of the patients with mild ILI, category A, do not require antibiotics, no steroids, do not give IM injection. Always, whenever you give a prescription, always write a word that counseling about warning signs has been given. and then tell them to come for periodic review, because many a times they will develop danger signs after the defervescence of fever, which the parents may not know unless you insist. Otherwise, they will tell doctor sarika pannittilla, sir counseling kodutilla. You just note it down in your prescription. Your prescription will save you in the court of law. So, having made 91% diagnosis of ILI, next important thing in your practice, you must know these very important 12 comorbid conditions. If you know these 12 comorbid conditions, automatically a child with a simple ILI, if they have got comorbid condition, for example, obesity more than 40, automatically it becomes category B, even if the symptoms are mild. So, knowing these 12 comorbid conditions is very important. The first list is very easy: chronic disease of the brain, heart, lungs, liver, kidney, or immunosuppression, either disease or drugs. Pregnancy, we must educate our colleagues. Children with COPD or asthma are at high risk. They have comorbid condition. As I told you, for obesity is a very important comorbidity, because nowadays we see lots of children with obesity, particularly after COVID. Even during COVID in our ICU, we had lots of obese children who have been ventilated, ventilated for weeks and months because of just obesity. So obesity is really a big one comorbid condition. Whenever you have an obese child, particularly with BMI more than 40, a simple ILI, category A mild ILI, automatically becomes a category B ILI. I'll tell you what is the difference between A and B. So if there is a diabetes mellitus, or children less than 2 years of age, adults more than 65 years, these 12 conditions makes a patient, these comorbid conditions makes a patient automatically to become category B. Category B in your practice is 8%. That is, as I told you, if they got severe disease or a comorbid condition with mild disease, category B. The main difference in category A and B is, in category A, I said no drugs, whereas in category B, you need to start oseltamivir just based on your clinical knowledge, without doing RT-PCR, without doing any lab test. So you can use your knowledge and use oseltamivir, but you have to be very cautious. You should use it. Suppose if you see 100 cases of influenza, you have to use it only in 8 to 9% of the cases. Do not misuse oseltamivir, otherwise if you misuse, you will develop oseltamivir resistance in the community. So you have to be very careful. If you prescribe oseltamivir, it has to be category B. Those children with comorbid condition or a severe disease. So even in category B, they can be managed at home. No need for admission, no need for blood test, no need for SHS or anything like that. No need for RT-PCR. Just start oseltamivir based on your clinical judgment. This is the recommendation by WHO. So if you suspect secondary bacterial infection, you can give broad spectrum antibiotics. In vast majority of the cases in our own hospital, having seen more than thousands of influenza during swine flu epidemic, our usage of antibiotics even in category B was less than 1%. So as a evidence-based practitioner, I would recommend in category A and category B, do not use antibiotics. That is, in 99% of the cases of influenza, do not use antibiotics. Now, having seen this, now we have 99% of flu is over. Stress is only 1%. So first we saw a child with fever, then we made a diagnosis whether it is bacterial or viral. Having made a viral diagnosis, we made a diagnosis whether it is respiratory or non-respiratory. Having made a IL respiratory, we wanted to know what are the viruses that belong to this family. Then we made a diagnosis of broad categorization into A, B, C. A is 91%, B is 8%. So 99% of flu is over. Now, rest 1% is based on the danger signs. If a child has got undue tachycardia or undue tachypnea or dyspnea, if you have a low SpO2 less than 94% by pulse oximetry, Pulse oximetry is very, very wonderful tool, like in COVID, in influenza also. They got hypertension. Many times these children will go in for hypertension, particularly those with comorbid conditions, chronic disease of the lung or other organ systems. They go in for hypertension as the disease progresses. Sometimes you don't see children with cyanosis or dehydration. Please remember, drowsiness, dizziness, seizures are all very, very important danger signs. And as with any other viral illness, abdominal pain, particularly at the time of defervescence of fever, is one of the important danger signs. When you have danger signs, these 12 danger signs, automatically the child becomes category C. So in category C, you have to do 5 things at the same time. On one hand, you have to take a throat swab culture. On the other hand, you have to give oseltamivir. 2 things at the same time. If you have a small clinic, if you have a child with category C flu, refer them. In hospital, you isolate them, you admit them, you intimate the health authorities, you do tests, you do treat. All these things have to be done at the same time. So one hand oseltamivir, another hand RT-PCR. So in 1% of the cases where you will have danger signs, you need to do RT-PCR. Other than that, you need not do routine RT-PCR for all flu cases. Because our resources are limited, we should not waste our resources. You can clinically manage them as category A without oseltamivir, category B with oseltamivir, without RT-PCR. In category C, you need to do RT-PCR. And you need to start oseltamivir as early as possible. In category C, when the vitals are unstable, many times you do have sepsis. So you need to cover the child with IV broad spectrum antibiotics, anticipating ARDS, pneumonia, and pulmonary sepsis. They are very high in a child with category C. So keep that in the back of the mind. So with that, so let's see what as a practitioner, if you do a CBC, most of the time counts will be normal, neutrophils will be normal. Sometimes you can have bilateral infiltrates mimicking ARDS, and sometimes you do have LDH that is elevated. In severe cases, in category C, if you don't promptly treat or don't refer early, mortality is really high, nearly 50%. So if you have such a child with such a pattern, if you look at the X-ray on both sides, so probably you're dealing with influenza, probably child is sick, refer them early. So this is finding study population in XHS in children with influenza. Vast majority have got bilateral interstitial infiltrate, nearly 40% of them. So please keep this in the back of the mind. So the timing of treatment is very, very important. As per New England Journal of Medicine, oseltamivir has to be given as early as possible, preferably to have the best results within 48 hours, within 2 days. But however, antiviral treatment initiated even after 48 hours can still be beneficial to the patient. You need not, if they come to you after 48 hours, if you make a diagnosis of influenza, you can even give and start oseltamivir. That doesn't mean you may not start oseltamivir. That's very, very important point. So let's come to the dosage. This slide is very, very important. Suppose if you want these my slides at the end of the meeting, I display my number. You can send a personal request. I'll send you the slides for you to read at home. Please remember, oseltamivir you should not give for neonates less than 14 days. There is no evidence as of now. For children less than 3 months, the dose is 12 milligram. Why it is 12 milligram? 1 ml of syrup contains 12 milligram. That's why it is 12 milligram. From children between 3 to 5 months, 20 milligram. 6 to 11 months, 25 milligram. For treatment, the dose is, for example, for a child with 6 months age old, 25 milligram BD for 5 days. Suppose if you want to give chemoprophylaxis, there is a category C patient at home, had exposed to all other persons. You need to give OD for 10 days for contact of severe category C patients. You need to give the same dose OD for 10 days. For children above 1 year of age, mainly it's based on the weight. If it is less than 15 kilos, 30 milligram BD for 5 days. Then as per the age, the maximum dose for children above 40 kilos and adults is 75 milligram BD for 5 days. So coming to antivirals, the commonest antiviral that we use in our practice is oseltamivir, either capsules or syrup. Syrup is 12 milligram per ml. Capsule, you got 75 milligram capsule. Though there are preparations 60 milligram and 45 milligram, 30 milligram, they are not commercially available. For children more than 7 years of age, you got inhaled preparation called zanamivir. We had one opportunity to use of zanamivir in a child who had a severe COVID and also category C influenza. In that child, the child was more than 2 years. We gave IV perennial, we saved the child. That's an imported drug from US. We saved the child. That's a very, very rare indication. And now Nelson's textbook of pediatrics recommends nucleoside analog Valaxavir for children more than 12 years of age. So the next question is, sometimes should I think of secondary bacterial infection for every viral fever? Should I prescribe antibiotics? As I told you, in your day-to-day practice, secondary bacterial infection is practically zero. Do not prescribe antibiotics if you make a diagnosis of viral fever. So when do you give secondary bacterial infection antibiotics? One is recrudescence of fever. Fever disappeared completely. After 3 days, 4 days, fever reappeared. Probably not related to the virus, probably because of the secondary bacterial infection that has happened beyond the viral period. Third is prolonged fever. For example, if we have most of the viruses, the fever lasts for 5 to 7 days. More than that, doesn't last, unless it is HLH or something other than that. In those cases, if we have markers of fever, the laboratory markers like elevated CBC, CRP, with polymorphic predominance, with a respiratory infiltrate, you can give antibiotics. Or there is a deterioration of clinical condition for category C. Otherwise, antibiotic prescription in flu is practically zero. So how to differentiate between flu and a common cold? Many times they come to you saying it is flu. Suppose if it is a gradual in onset, most of a running nose, stuffy nose, sneezing, without myalgia or fatigue or mild fever, probably it is common cold. So you need not treat those children. On the other hand, if you have a sudden onset of high-grade fever, severe body pain, with less of nasal symptoms in young children, you think of flu and then categorize them as A, B, C and treat them. So, as I told you, you have to please remember the rule of 2 hours of incubation period, 2 days of fever, 2 weeks of cough, and 2 months of asthenia. So, sometimes you do have extrapulmonary manifestations of severe flu, particularly in the like hemodias, shock, renal failure, coagulopathy, but very, very rare. But still, you need to keep in the back of the mind. Sometimes during a flu season, you can have a child coming to you with otitis media. Please remember, during a viral fever season, during the epidemics of flu or dengue, nearly 25% of the febrile seizures that come to you are because of flu or dengue. 25%. So always you have a child with sudden onset high-grade fever with febrile seizures. Keep these 2 viruses in the back of the mind. So let's come to the last part of the slide. Wherein you have vaccines. In vaccines, you got live and inactivated vaccine. Live vaccine, we had a nasal live vaccine, which was called NasoVax by Serum Institute. We gave it during the swine flu epidemic. So now it's not available. It's a live attenuated virus given nasal spray, 0.5 ml into both nostrils. It's given for children about 2 years of age. Please remember, being a live attenuated product, it should not be given during pregnancy. Now what we have is inactivated influenza vaccine. It is given as IM. It is given for all children above 6 months of age. Below 6 months, you have transplacental antibodies. It is safe even in pregnancy. The dose is from 6 months to adult age group. The dose is same, 0.5 ml IM. There is previously we had below 3 years 3 to 8 years and more than 8 years. Now everybody knows it says 0.5 ml. Only thing is, when you are giving for the first time, if it is a child less than 8 years of age, you have to give 2 doses. For children more than 8 years of age and adults, even for the first time, it's only 1 dose. So please remember, this is a virus that keeps changing its envelope every year. So annual revaccination is mandatory. And please remember, flu vaccine can be concomitantly given with any other vaccine. Suppose if you have somebody with egg allergy, the egg component in the influenza vaccine is very low, but to be on the safer side, you give the vaccine with precaution. What are the precautions? You need to have oxygen, you need to have adrenaline, you need to have hydrocortisone, you need to have ambubac and other things. You need to give the vaccine in your ER. All these things are precautions, but you need to give the vaccine. If there is egg allergy, it's not a contraindication for flu vaccine. So having seen this, so what are the indications? Ideally, the recommendations to all children above the age of 6 months of age, but you need to give this vaccine based on priorities. So priority is 6 months through 4 years, 59 months till 59 months of age you need to give. For adults more than 50 years, for practical reasons, to all doctors above 65 years of age you need to give. Those having chronic illnesses, as I told you, those who have comorbidities, you need to give vaccine. These are all very, very important priorities for this vaccination. So as I told you, cough seems to be the predominant symptom in a child with influenza. So let us have few slides on cough before I end my talk. So please remember, as per Nelson textbook of medicine, avoid cough syrup in children less than 2 years of age. And sometimes you have a cough syrup that contains many ingredients put into the same bottle. One antihistaminic, one decongestant, another mucolytic, another bronchodilator, cough suppressant, all having opposite action put inside a single bottle. If you give this polypharmacy syrup, nothing will act. So always go for monopharmacy. If you have a bronchospastic cough, give salbutamol. If you have a dry hacking cough, isolated cough, give dexamethasone. So you need to know what is the cause of cough and then treat accordingly with a monopharmacy, no polypharmacy. Very, very important message. So if there is a common cold, as I told you earlier, try to give first generation antihistamine. What is the idea of giving first generation antihistamine? It crosses blood-brain barrier. For example, diphenhydramine given at 5 mg per kg per day, Q6 hourly. It crosses blood-brain barrier and also not only reduces the cold, but also reduces the irritability, sleeplessness, all those things. And even if you want, you can even give it to the mother. She can also have a peaceful sleep. And in children with dry, isolated dry cough, nothing other than cough, you can use dexamethasone at the dose of 1 mg per kg per day, 8 hourly. Please remember, do not use codeine. So sometimes your cough syrup itself can cause tachycardia, SPT, and drowsiness and dizziness. So you have to use, like antibiotics, you have to use cough syrup with caution. Never use it below 2 years of age. Suppose there is a history of allergic rhinitis. There is history of allergic rhinitis and the child has got postnasal dribbling. And child also had a history of plexural eczema. And the family history of allergy is there. You can give second generation antihistamine for full-grown child because these do not cross blood-brain barrier and the scholastic performance is not involved. So you have to give second generation antihistamine like desloratadine, levocetirizine, or your hexapenidine. So, for example, the mother comes and says, every night child gets a cough and there is no fever and there is a family history of allergy or atopy or asthma or a wheeze. In these conditions, chronic afebrile dry nocturnal cough, probably they are all bronchospastic cough, probably child has got hyperactive airway disease. So when you have a doubt, what you can do is you can give a nebulization with short-acting beta-2 salbutamol. After nebulization, if the cough suddenly abruptly comes down, it's probably a simple hyperactive airway disease. Just prescribe salbutamol, no antibiotics, nothing. Do not take XHS. send them home with salbutamol alone. So, in one condition where you have chronic wet cough, this is recommended by European Society of Pediatrics. That's called protracted bacterial bronchitis. This is the only condition in which you got evidence for prescribing antibiotics in a cough. Otherwise, in a simple cough, most of the time are viral triggered. They do not require antibiotic, or they do not require manto, or they do not require any extraction. Unless you suspect foreign body or a sudden worsening of a pneumonia, do not do an extraction. Okay. So, what is the remedy for children below 2 years of age? I said not to give below 2 years cough syrup. So, you can use honey. North American Pediatric Clinics of North America and WHO recommend honey. It has got a good demulcent effect, antioxidant effect. It has also released a cytokine that is got pro-inflammatory action and with an excellent safety profile. The dose is around 2.5 to 5 ml. Either HS with warm water, or a tumbler of warm water, or you can even give it TDS. It's very, very safe. Do not use it below 1 year of age. Always, as a risk of botulism, always you use pasteurized honey. So let's come to the carry-home messages in flu. The first and foremost important thing is wash your hands between two patients. And doctors usually get this influenza often from the parents, because during this monsoon, I request all the doctors to have a busy practice to wear masks and never take your hands to the face, because 1 square inch of your hand will contain more than 1 lakh influenza virus. If you touch that patient and touch your face, the virus will go inside. So that's called hands-off face technique. So that's very, very important. And cough etiquette is very, very important thing that you need to educate the parents, particularly young children, to close like this and then cough like that. So avoid handshake during influenza outbreak, because as I told you, hands are the carrier of influenza virus. And most important message to all the doctors who are joining this conference is that please take influenza vaccine as early as possible. I have taken this vaccine for the past nearly 20 years. I am a part of Influenza Foundation of India. So I request everybody to take the vaccine. So last slide, 91% of the flu are mild in nature, called category A, no test, no oseltamivir. 8% moderate illness with comorbid conditions. Even in these 8%, do not do any test. You can give oseltamivir, but you need to write your diagnosis board. Category B, as per WHO, you start oseltamivir. Do not misuse oseltamivir. Only in 1% severe disease, you need to do all the 6 things at the same time. So with that, I close my talk, and then you have my number here, 984221179. You can send a request to me by WhatsApp. I'll send you the slide. 984221179. So if you've got questions, you can put it in the chat box. I'll be happy to answer.
Thank you, Neminathan sir, for the excellent talk. Now it is time for discussion.
Yeah, there is a question sent to me. If there is a child with a cough, fever, and a conjunctivitis, how to proceed? There is a question sent to me. Luckily, I got a slide for that also. Suppose if you have a child, if you have the child with conjunctivitis, with cough and fever, so how to proceed? That's the question. So sometimes you do have a child coming to you with high-grade fever, watery diarrhea, dry cough, conjunctivitis. Sometimes you will have a painful, child will be telling, child has got painful urination, the mother will tell, sometimes the urine is red. In such a situation, please remember, this is most probably, as I told you, this is a virus, and this virus has got prediction for both for conjunctiva and also urinary epithelium. There is only one virus You can make a diagnosis just by taking the history. That's the adenovirus. So combo of respiratory, GI, eye, and urinary system is until proven otherwise is adenovirus. Please remember, if you do a urine microscopy, pustules will be there more than 10. But if you do take a culture, it will be negative. It's called sterile pyuria. So even there is a pustule, you need not give antibiotics in adenoviral infection. Please remember, this is the virus that mimics bacteria. It's a great mimicker of bacterial infection. Sometimes if you do CBC counts will be high, 17,000, 18,000. If you do CRP will be 20, 30, 40 like that. CRP also will be high. But your symptomatology, your signs and symptoms, sudden onset with eye involvement, all these things will swing the pendulum towards adenovirus and do not prescribe antibiotics. And please remember, based on a single CRP, do not make your diagnosis bacterial. You have to do a serial CRP, it is gradually rising. Then you have to think of bacteria. Many times, even in viral, you can have a CRP elevated, you can have a count that is elevated. And most important thing in adenovirus is if you have an eye involvement, particularly keratoconjunctivitis, you need to refer to ophthalmologist as early as possible. And the child is immunocompromised, you need to refer them to eye center because these are children who need a drug called tenofovir. So they will go in for early hypoxia and sudden shock. They will need HFNO. So at present, we don't have vaccine. Only most important thing is we had an outbreak of adenovirus a couple of months back in the country. You can have unilateral hyperlucent lung in post-adenoviral condition, probably due to fungal sepsis. Okay. So suppose if the child develops a conjunctivitis following a pneumonia after 1 week or 2 weeks, you need to think of atypical organism, chlamydia or moraxilla, you need to give azithromycin. The child develops pneumonia conjunctivitis after 1 to 2 weeks of pneumonia. Think of atypical organism. Okay. Next, there are any questions in the chat box, you can let me know.
Vaccine போட்டுக்கணும் influenza vaccine. Viral fever அதிகமாயிடுச்சுல. Vaccine.
So please mute yourself. Do not talk in between. Somebody can go to the chat box and ask questions.
Yeah, yes, sir. There is one question about, sir, in case of allergic rhinitis in an atopic child, what can be used for cough?
Yeah, if there is an allergic rhinitis in an atopic child, most of the time children with the atopy, they have an allergic mark. Most of the time they do have hyperactive airway disease. Salbutamol is the safest. The cough is persistent for a longer period. If it is an older child, more than 6 years of age, you can do pulmonary function test. You can prove bronchospasm, and then these children you can use inhale corticosteroid. Or if it is a sporadic once in a while cough, then you can give oral salbutamol is sufficient.
And one question is regarding febrile seizures. I think this is not a topic we are discussing today, as febrile seizure itself is a topic with vertigo. Another interesting question is that after an episode of influenza-like illness, when can you give vaccination? This is an interesting question, sir.
Yeah, very interesting question. Whenever you have any viral illness, particularly whether it's influenza or a DLI or anything, you need to give a period of 2 weeks. As early as possible, after 2 weeks, you need to give the vaccine to the concerned given child. To the household contacts of a child with ILI, other children, they need to take it immediately. When you make a diagnosis of ILI in this child, you need to give same day, you have to give vaccine for younger children and also for elderly, more than 65. And the most important thing, the doctor who advises influenza vaccine to others should take the vaccine after the CME.
Now, in that case, there is a question, sir. If you have a contact in your family and you are giving a vaccine to the contact, how far it is protective? What percentage of patients will
actually be basically this influenza vaccine protection rate is very low. It is not like other vaccines. Protection, some of the studies as low as 30, some of the studies as low as 70. But by far it is around 55%. So, but considering the comorbid condition, the age and the severity of the illness, and not only that, most of the time the death in influenza happens not because of the influenza virus. It is following the secondary bacterial infection that causes in elderly immunocompromised individuals. So in order to save the other illnesses following influenza, we give influenza vaccine. It is not influenza per se.
Yes. Sir, can you unshare the slide so that we can see each other?
Yeah.
Yeah. Anybody want to ask any questions, please? You can unmute yourself and ask questions.
There was a question, why no ibuprofen and mefenamic acid? Yeah, please remember the WHO in the dengue guidelines recommends not to use any other paracetamol other than so not to use any other paracetamol other than any other antibiotic other than paracetamol. So always it is safe to use only paracetamol because all these ibuprofen, all these NSAIDs have got antiplatelet action. So the child will have, if it is going to be dengue or any other viral illness, they will cause thrombopenia and bleeding. Can you hear me?
Yeah. Yes, sir.
Yeah. In order to reduce the risk of bleeding in children with DLI, you need to avoid ibuprofen and other mefenamic acid.
Yeah, thanks, sir.
So please remember, most of the time, the parent's concern will be to reduce the fever, but our concern should be to make an empirical diagnosis and treat the cause of fever, do not reduce the fever. Previously, I used to get children with fever not coming down. They have the classical biphasic fever or fever once in 2 days. All your fevers, undulant fever, all those things will be coming previously. When I started my practice, we used to make diagnosis of fever, the cause of fever by looking at the fever pattern. Nowadays, I get severe pneumonia without fever because they have pumped in all drugs, paracetamol high dose, ibuprofen high dose, mefenamic acid, combination of mefenamic acid with paracetamol. Child comes to you without fever, but with a severe pneumonia. So, we need to avoid indiscriminate use of antipyretics. Use only paracetamol. Do not give IM injection. Do not treat the fever. Treat the cause of fever.
Okay. So we are very quite happy that we have more than 100 people in the Zoom platform, and there are so many people are there in the YouTube also. And it was a first episode of our program is wonderful. And if you have any questions further, you can put in the group also, and Dr. Neminathan sir will be contacting personally, replying for that. I think I thank Dr. Neminathan for this wonderful program, and I thank Madhyakerala branch also for giving me the opportunity, and thank all the participants who has come up for the program, especially people like Dr. Srinivasan sir joining from US as a very encouraging thing for us. Now over to Dr. Soli for vote of thanks.
So before Soli, I like to thank the president of Madhyakerala, Dr. Rafiq sir, Simi Polo sir. I also thank to Ashok Kumar sir, so Soli, who has been coordinating with me. So my sincere thanks to everybody. So I always have a close affection and a close contact with my friends in Kerala, as I have my roots in Kerala. So I really appreciate Madhyakerala for the initiative. First time itself is a big crowd has come, a century you made. So my appreciations and wishes to you for the future, all programs that you do. My appreciations and wishes, sir.
Thank you. Thank you, sir. Oh, Soli, over to Soli.
Sir. First of all, I thank Neminathan sir for the excellent talk. It was simply superb, sir. Thank you for sharing your knowledge and practical experience with us. And next, I would like to thank IAP Kerala, Dr. Shimi Paulo, State President, for all the support and encouragement for conducting the program. And special thanks to Dr. Rafiq and Dr. President IAP Madhyakerala and Dr. Ashok Kumar sir, CIAP EB member for all the guidance. I thank the senior members and IAPians from Kerala and Tamil Nadu for encouraging us by attending the program, attending the talk in large numbers. I thank all the delegates who found time in spite of the busy schedule to attend the meeting and make it a big success. And I ask everyone to continue learning by attending future sessions. Thank you. And I request everyone to switch on their video so that we can take a screenshot. All the available members.
Dr. Soli, you have not opened your video.
No, sir, it is open.
No, your video is not
No.
Maybe. Okay.
Is mine open?
Yeah.
It is showing open.
You can just close and open it once again, then it will be.
It is open only, but I don't know.
Anyway, it's
We
okay.
are not used.
Fine.
Okay, no problem.
Okay, Dr. Rafiq, you can close the program.
Okay. Okay.
Yes.
Over to Rafiq, sir.
I think I told him to close the program. He closed himself and left. I think Soli, you can just say bye and finish off it. Yeah, Rafiq has.
Okay, bye, sir. Bye, everyone.
Okay, sir.
Thank you.
Okay.
Thank you.
Thank you all for joining, and we will come back with the next program. We will let you know.
You can ask the participants to rate the meeting, sir.
Yeah,
so that we can improve upon the next meeting.
Somebody please. Can somebody say, open their video and say something? You can unmute yourself and say.
Any participant?
Sir, will there be a change in time in future sessions?
We can discuss it and settle it, sir. We can discuss it.
Yeah. You can have it. They want it between 9:30 to 10:30. What time you want?
We will discuss it in subsequently and finalize it, sir.
Yeah.
We will not be in the open forum. We will discuss it.
Yeah.
Okay. Okay then.
Yeah. Thank you all.
We call it a day. Okay.
Thank you.
Bye.
Thank you. Bye.